Hi, I'm Simon Merritt. I'm Chief of Medicine, Consultant in Respiratory and Sleep Medicine in East Sussex Healthcare Trust. I've been here now almost 12 years.
Brilliant. And what was it that made you first want to go particularly into the respiratory side of things?
I like the fact that it was very general. I don't like the fact that at the moment people are going down a specialty route and ending up in a very niche area where they just do a very small thing and don't do other things. I like the fact that respiratory encompasses things like connective tissue diseases causing ILD, pulmonary hypertension, the fact that it encompasses operative procedures in terms of tunneled chest drains, bronchoscopy, endobronchial ultrasound, thoracoscopy. So it's got a nice balance.
And did you always want to go into respiratory?
I was inspired by a consultant called Jeff Pack, who's long since retired, when I worked at Newham Healthcare in East London. And I was inspired by him, inspired by his generalist approach, knew quite a lot about almost everything. And from then on I looked into it and did my MRCP, a locum reg job in respiratory medicine, and then I got onto the respiratory registrar training rota.
Okay, brilliant. And during that time, have you got any regrets at all about that decision that you've made?
No, not in terms of training in respiratory medicine. During my training, I spent some time doing sleep medicine as well. I did my research in looking at the physiology and breathing in the morbidly obese, and then also into instance of instance of severe type 2 diabetes in sleep apnea, and then looking at retinopathy and finding that if you've got type 2 diabetes and sleep apnea, your retinopathy is likely to be worse than otherwise. And that sort of kindled my interest in home ventilation and in sleep medicine, and that's those. Although I said I didn't like people in niches, I do those two niches here. So I run the sleep service and the home NIV service, but I also do general chest medicine as well.
Okay, brilliant. And what would you say to those students or junior doctors who haven't quite decided about which route that they want to go down?
So I do two separate answers. So firstly, to the student, I would say don't even try and decide now, because you need to be doing things, you need to see what they're like before you make any form of decision. And I think it's a mistake to go into medicine and make your mind up very, very quickly before you've experienced other things. I'm going off on a tangent, but I actually had a place on a surgical rotation to do surgery in Eastbourne in 2001, I think 2002, and at the last minute I thought, actually no, it's not the right thing for me, and then I went off and did a job in A&E in Margate. So I had been absolutely sure since I did trauma in South Africa as my elective, I wanted to do surgery, and then I did surgery as an FY1, and I thought, well, actually no, it's not something that I want to do, but I'd already gone through with applying. So I wouldn't make a decision too early. I would experience things. You can't know what things are like as a consultant from working in them, whether you do taster weeks or days or even as an F1, but you can get an idea of the sort of thing that happens, whether it's something that you want to do that is very hands-on and operative with little ward care, or actually whether you want to spend more time on the wards, more time speaking to people. And if you're really sort of a people person and you like spending a lot of time trying to uncover what's going on with the patient, then looking at perhaps as a non-surgical specialty might be the way forward. But there are lots of those, and obviously I would include general practice in that as well. Okay, and in terms of advice for people who are already working, then again I would repeat what I've said already. You will start to have an idea of what it is you like and what you're good at as well. And one of the other things that put me off surgery was, as a medical student, I think a senior registrar said that I had the manual dexterity of his 5-year-old daughter or something like that while I was assisting in surgery, and that made me think somewhat as well. I mean, I like to think my dexterity is better than that, but in the old days that was quite a common sort of comment. So I think, and I would speak to people as well. I'm very happy for people to come and have a chat with me. But medicine is evolving hugely, and from when I qualified in 2000 to now, it's very, very different. It's almost unrecognisable, and I think it will be from today's F1s and medical students. For when they become consultants, it will be very, very different again. And so you shouldn't make too many decisions based on what it's like now. You've got to go with what you're good at, what you enjoy doing, and also bear in mind that you spend a lot more time as a consultant than you do as a junior. So a lot of people these days are saying, I don't want to do medicine because I want to be a medical registrar. Well, I mean, that's 5 years, and it may be interrupted by time off doing research and things. But actually that's 5 years versus, and you become a consultant by mid-30s, I guess. And then you've actually, at current retirement, you've got another 30 odd years to go. So you're going to spend a lot more time as a consultant than you are at any other level. So don't not do it because a very short piece of part of the training is something that people don't want to do. Being a medical registrar is actually quite good fun. It's quite stressful, but basically the hospital depends upon you. And as long as you always go back to basic principles of ABC, of making sure that you have to know what's going on with the patient, but you need to want to stabilise them, you involve other people, you ask for help. It's actually a very, very good and very enjoyable job to do.
Brilliant. And then you also said at the start that you're now the Chief of Medicine. Yeah. And what was it that made you go into the management side of things?
Leadership rather than management.
Leadership.
But we have lots and lots of managers that we pay to do the job. So I started off as a clinical unit lead, which is we used to have the structures of clinical units rather than divisions, and so I did that for 4 years. And then 3.5 years ago, they changed the structure because we used to have cardiovascular, diabetes, and stroke separate in their own unit. So we merged those into the rest of medicine. Excuse me. And then we came up with medical division and a chief of medicine, and I have 3 deputy chiefs. Why did I want to do it? I wanted to do something different. I wanted to be challenged more. I enjoy working in leadership. I spend probably about 40% of my time, maybe 50% of my time doing leadership, and then the rest of the time being on call, doing clinics. And a lot of my time doing leadership is actually on the wards, going and talking to people anyway. So whilst I might not be actually caring for a patient on that ward, I do like to meet everybody and hear for ideas and issues and complaints. It's very rewarding indeed. It's not easy, and there are some days where I wish I didn't do it, but most days I wish I'd do. I'm glad I do it, and I would thoroughly recommend it. There are lots of routes into leadership now, so there's the Darcy clinical fellowships that people can go into. There are leader fellowship posts that some trusts have, and then also actually just learning as you go along as well.
And I'm sure kind of over your career there's probably lots of stories of particular patients or cases that you've looked after, but I was just wondering, are there any that come to mind now, either good ones or maybe ones that you learned from that you could just share with us?
I mean, I guess I'm going to ramble a little bit. I can
pause it if you want to think for that one. Or you
No, I'm fine. So I think, I mean, There are lots and lots of mistakes and errors I've made in my time, and I think that's a really important thing, and I'm going off on a tangent a bit, but we have to accept that we're all human and we all make mistakes, and there are many, many things. I mean, I may not be able to remember many details, if any, but there are certainly things that I look back and think, oh, actually, I shouldn't have said that. So errors in communication with patients or family members. And indeed, actually, if I could have my time again, I would have not done this, or I would have acted on this or this result. I think the key thing, though, is that when these things happen, that we reflect on them and we learn from them, and we try to ensure that A, it doesn't happen to us again or to our patients, but B, also that we report it, and therefore, if it's something that is a common theme, that we can then share it more widely. Because a mistake you make or a mistake I make is very unlikely to be the first time it's happened or the last time. And if we don't report that, then someone else is going to make the same mistake and again and again. And we know that when we have something posted on a Datex as a near miss, and we have lots of those, and that's good because that's what we want. We want near misses rather than actual events. We know that there are many other people. For every one that's reported, there are going to be 2, 3, 4, 5 plus that have never been reported. And so when we get a cluster, we then will share and we'll send emails out and we'll share with teams, actually this happened and this happened. A near miss, this was a long time ago. So I was doing a lumbar puncture, or about to do a lumbar puncture for a patient when I was working in Newham, actually, as an SHO level doctor, so equivalent of CT one or two, I can't remember which now. And we were doing it by the bedside. It was a patient with HIV who was confused and agitated, and we were going to sedate them. And I had all of the drugs in one of those little cardboard vomit bowl things, and the nurse was handing them to me. I'd drawn everything up. I hadn't labelled stuff, but it was, when I say all the drugs, the lignocaine was separate to the sedation. And then, so I asked for the sedation and I was handed it, and then I was just about to give it when I realised actually it was lignocaine rather than sedation. So I would have given it IV, probably would have ended quite badly. And so I've learnt a lot about labelling drugs, about not preparing too much in advance, especially when actually once you're given a sedation, you don't need to have the lignocaine ready straight away. You can do it later on. These days we probably wouldn't be giving IV sedation just on the bedside with just a nurse to assist, but things were quite different at that stage. And as I said, I mean, a lot of I think things that we perhaps underappreciate in terms of reflecting on errors and mistakes revolve around communication. So I'm sure I could look at your portfolio, or you could tell me about it, or indeed a number of other people, and the stuff people have reflected on is physical problems like the one I just described. But actually, in terms of patient experience, in terms of stuff that comes across my desk as complaints and things like that it's almost all communication. It's not, you almost gave me lignocaine. That's very important, but it was really hard to find out what's going on. I got conflicting messages. I didn't really know I was going home. This wasn't done. So I think actually that the lesson, one of the lessons for me, is that we perhaps need to be reflecting more on some of our communication issues as well as the things that we physically have missed or haven't done or done an error.
Okay, brilliant. I think that's everything we've got to chat about, so thank you so much for taking the time for that. Anything else you'd like to say?
Well, I would put a plug in for respiratory medicine, which I've failed to do so far. I mean, I think it's an excellent specialty. We'll wait, it's fine. Don't worry. That's all right, it's a helicopter landing, I think, isn't it?
Oh, is it landing here, is it? That might be going on for a while, mightn't it?
No, well, it may be. We could just go into the reception area and do it if you want the last bit. Oh, that's probably all right. Okay, fine. Do you want to ask the question again and then you can look at it?
I was just saying, okay, well, thank you so much for the time you've done there. Is there anything else that you'd like to say to the students? Well,
I haven't plugged respiratory medicine as much as I should do, or sleep medicine at all. So sleep medicine is wonderfully interesting. It's not a specialty at the moment that you can train formally in, but it's something that as part of psychiatry, sometimes ENT, sometimes anaesthetics, frequently neurology, or indeed very frequently respiratory medicine, that you can get subspecialty training within. It's a very small field. The British Sleep Society only has about 300-400 members, and that's not just doctors. In fact, doctors are a minority. The beauty of it is that it contains all of the specialties I've mentioned, so airway stuff with ENT and anaesthetics, mechanics of breathing with respiratory, neurology in terms of funny things that happen overnight, so people acting out their dreams, nightmare disorder, PTSD, and obviously psychiatry is a big part of that as well. So it encompasses all sorts of different specialties. It's really interesting. Sleep apnea is one of those few things that we see in medicine where easy to diagnose, easy to treat, patients get better within a couple of days. Most of the rest of the stuff we do, we help people to get better who were probably going to get better anyway. We control their symptoms, but really you make a huge difference to people's lives. They're able to go back to work, to drive again, to function properly. And then things like insomnia as well, harder to treat, but very interesting and very satisfying treating. And respiratory medicine, so many different things you can do, from infections, in terms of infectious diseases and things like TB, which at one point people thought was going to be conquered, and therefore respiratory medicine wouldn't be needed as a specialty, but we were very wrong about that. To pulmonary hypertension, to just general generic breathlessness, so looking holistically at breathlessness, to cancer, to all the procedures we've mentioned. And there's loads and loads more. So it's very, very interesting, very satisfying. And we're quite nice people, respiratory consultants.
Brilliant. Thank you very much.
Pleasure. Thank you.